thinking of all the things I should be thinking about. And then after 18 years, I joined Sanbus. And I think the first 6 months in Sanbus was the biggest eye-opener of my life, because I started stumbling on all this information that nobody ever shared with me when I was still in clinical medicine. And I think that's why I'm so passionate about this topic, because I really think somebody should be talking about this. And then I ended up to be it for the blood services, at least. So let's get going. So I'm a firm believer in informed choice, and therefore I always start with the summary. So in case you have to leave early, that's the summary of the talk. So that little diaper-wearing devil there on the left, I'm sure he is family to the tech devil, but he actually is the law. And then our fairy godmother in this whole scenario is patient blood management. And you actually need to be able to tick all those boxes to ensure that your patient have the best possible outcome. Otherwise, if you just tick one or two of the boxes, you are still going to have blind spots and problems. It's important to take note that in the South African setting, it's almost impossible to separate the law from ethics. The two are so closely joined and so closely related that one doesn't really talk about the one without consideration of the other. The same with patient blood management and optimized patient outcomes. I don't think we can separate the two anymore. If you want to optimize patient outcome, you must be cognizant of patient blood management principles. So why do we get involved in this discussion as a blood service? Because like Vernon told you, George reduced their blood usage with 50%. So why would the blood service, who kind of everybody thinks sells blood, although it's not the case, are talking about patient blood management? And I think it's simple for us because our purpose is to be trusted to save lives. And our vision is to become a cornerstone of healthcare services in South Africa. And if we are not the ones being able to step up and talk about these issues, we will never meet our purpose or our vision. So a lot of things has changed over time when you look at ethics. And one of the big things that changed is that it's not just about the right choice with the information I was trained on, let's be honest, 31 years ago. It's the right choice considering the circumstances that is currently at run and at play in your environment. And therefore, transfusion ethics is no longer just blood transfusion. It is actually about the fact that we have a duty than just the patient sitting in front of us. Our duty as healthcare workers go far wider than the one person sitting in front of us. And therefore, our actions and our thinking shouldn't be, how do I prevent a transfusion? But it should be, how can I contribute to the broader public's best interest? And how can I contribute to making sure that every individual out there reaches their full health potential? And that's a concept called health equity. So patient blood management is widely published, and it really, we can't say we did not know anymore. Those days are gone. So it should form part of our patient evaluation, our patient interactions, and most definitely of our treatment plans. So a lot of the headaches are ours, and we just spent a day and a half brainstorming how we are best tackling this going forward for the next 5 years. So that's my gray hairs and my sleepless nights. I think for you, we are just going to talk about what relates to the practicing doctor in South Africa. Let's start with the ethical considerations. So Koski said that ethics is the branch of knowledge that deals with moral principles. And you all know that doctors have the ethical obligation to benefit the patient, avoid harm, or if you can't avoid it, at the very least minimize it, and to respect the values and the preferences of the patients. You all know the 4 principles of bioethics. They've been around for very long, and you may find situations where the one is in conflict for the other. And in those cases, that which weighs the heaviest, given that specific set of circumstances for that specific patient in that specific hospital, should be considered. And all transfusion-related decisions should be based on these 4 principles. So let's start in the beginning, because that's a good place to start. And autonomy is the first thing we need to think about. And that's the capacity of a rational, competent individual to make an informed, uncoerced decision. And it's important to always remember that a competent adult have the right to decide what will or what will not be done to their bodies. So what does it mean for the world of transfusion? Informed consent and informed refusal. So on informed consent, there are a couple of requirements that the HPCSA wants us to know or to think about. The individual must be competent to understand, but they must also be able to comprehend the disclosure. So we can't use this high convoluted terminology because they will not understand or comprehend what we're telling them. They must receive full disclosure. We can't decide what we will tell and what we will withhold. And the information we give the patient must enable the patient to make an informed decision. Then obviously the patient consents to the proposed intervention or treatment, irrespective of what treatment we are talking about, and this must always be documented. Now on informed refusal, we are doctors. We tend to want to help patients. We want to make everything better. And sometimes, especially when I was younger, it was extremely difficult for me to accept that patient says no. But we have to learn to respect the values and beliefs of patients when patient says no to us. The whole process and the whole discussion must still be documented because that is both an ethical and a legal requirement. Here's the big thing. When I go to hospitals and I speak to doctors and nurses in person, and I give this talk, and we cover 8 provinces, so we speak to a wide range of healthcare workers, you will every time have at least one doctor or one nurse approaching me afterwards and saying, you know, doctor, we have noticed that during the day when the family and the friends are around, the patient says no to a transfusion. As it quiets down after hours, the patient will call us back and say, can you ask the doctor if he can do the transfusion before my family comes tomorrow? So I think I learned a valuable lesson there from our healthcare workers in the trenches, is that as much as the doctor can unconscious or subconsciously coerce the patient into saying yes, the family or the friends can coerce the patient into saying no. And therefore it's our ethical duty to ensure complete confidentiality for our patients so that they can truly make an informed, uncoerced decision. So also important to remember is that a patient that was previously competent and said no, and they are now incompetent to make a decision, we still have to respect their previously expressed wishes. Let's talk about beneficence. And that is our duty as doctors to act for the benefit of the patient and to promote patient welfare. And it's important to understand that beneficent actions can actually help to prevent harm and remove conditions that could cause harm to our patient. So in transfusion, what does it mean? It means transfusion must be based on a genuine clinical need, because the only safe transfusion is the one that you will never do. All transfusions come with a risk. And if we are to prevent risk or to minimize risk, and we are not sure that our reason for the transfusion is a true clinical reason, then we are actually being unethical. If any post-transfusion information becomes available of possible, potential, or probable harm, the patient must be informed. And that is where the country's look-back program, it's one of the hemovigilance surveillance programs, come in. And that is where we as a blood service, or Greg and Caroline down in Cape Town, as the Western Cape Blood Service, picks up a positive viral marker in a donor on a repeat donation. And then we have to retrospectively inform the doctor that the donor who tested negative when we issued your patient's unit has now come back and they tested positive. And then you have to participate because it is something that has got potential or possible harm for your patient, and therefore the patient must be informed. When any information around the transfusion must be confidential, please remember patients flip through files, they take photos, they Google. So please don't have any patient information lying around, and we can cause disclosure of information when the patient would not want it. You also are not allowed to limit your patient's options. So this means just because when I was trained, when the earth was still flat and patient blood management didn't really exist in South Africa in that era, it doesn't mean that I can just fall back on that and say, yeah, I don't know about that. I am not allowed to fall behind on my knowledge. I must make sure that my knowledge keeps up with what's happening out there so that I can continue giving my patient the most options available. So let's talk about non-maleficence. And that means you have to do no unnecessary or unreasonable harm. You're not allowed to expose patients to an unnecessary risk. Please do not deprive others from the goods of life. So in transfusion terms, what does it mean in practice? We're back to the fact that an unnecessary transfusion is an unnecessary risk. The risk of transfusion is not related to the transfusion episode. The risk of transfusion is related to each individual product that you're going to transfuse. So therefore, exposure to unnecessary products is also an unnecessary risk. You always obviously have to weigh the benefits versus the risk for any course of action, not just transfusion, and you have to avoid any unnecessary treatment. Now, if you have inadequate knowledge of the treatment, then therefore you are also going to expose your patient to an unnecessary risk. And that links sometimes very closely to the standard of care. When you're doing your ward rounds physically in the hospital, and you see blood standing at the nurse's station or blood lying on a countertop next to a patient's bed, but it's not your patient, so you walk on and you continue with your rounds. That is not acceptable because that blood is out of cold chain. Somebody needs to step up and say, this is a potential risk to the patient. We need to remove potential risk from the patient. So we need to act if we see anything in the standard of care of our patients or other patients in the hospital that might be detrimental to them. Sorry for that. A big thing is the use of uncross-matched blood from the emergency fridge. I'm not sure if this is such a big problem in the Western Cape. We don't cover the Western Cape province, but very much in the rest of the country, we find that uncross-matched emergency fridge blood is often used not because it's a life-threatening situation, but because it's logistically easier than sending samples in a request form to the nearest blood bank and waiting for the cross-matched blood to come back. So the use of uncross-matched blood is most definitely a big added layer of risk to your patient, and you must make sure that your reasons for doing that is correct. Likewise, if you are going to transfuse a patient booked for elective surgery, just because the patient is anemic and you don't want to cancel the surgery, that will be deemed unethical because that's an unnecessary risk that you expose your patient to because it's not emergency surgery, it is purely elective. So, the principles of justice, it talks about equal distribution of benefits and burdens. So in SANBIS, I have got the dubious privilege of when the stocks run low to send out the cutback letter, as our doctors call it. And we don't only send the cutback letter to the private sector or the public sector, we send that letter to everybody. If we have enough blood, everybody is fine. If we struggle with stocks, everybody struggle together. So it's equal distribution of benefits and burdens. It also speaks to fair, equitable, and appropriate treatment of all patients. So in transfusions, irrespective if my patient presents at Garden City in Joburg or in St. Elizabeth Hospital in Lusikisiki, it means that at least for basic health care conditions, my patient must have access to the same basic treatment. And all medical decisions relating to a transfusion should be based on the best available evidence and treatment options for that particular local circumstances. So if you do not have a cell saver in Springbok Hospital, and by the way, I think they do have one, But if you do not have a cell saver in Springbok Hospital, I can't fault you for not considering the alternative and using red cells from the emergency fridge for your PPH, because Springbok is 400 kilometers from the nearest blood bank. But if you follow the same approach in a hospital with a blood bank on site and who does have a cell saver, then your actions might be deemed to not be in the best interest of the patient. Patients should receive the most appropriate blood products available. Again, if my patient is bleeding, I would really now go into a massive transfusion situation. I would ideally want cryoprecipitate. We all know FFP is quite a difficult product to control the volume load of the patient with if you're going to start rushing in a lot of red cells and FFP. But if I'm in a setting where there is no cryoprecipitate, then FFP immediately becomes the most appropriate product. Patients should also only receive the products that are clinically appropriate and will give the patient the optimal outcome with optimum safety. And remember, if I waste in one area and the stocks run low, it means that a patient in Lusikisiki or Springbok who has to wait so much longer for the little courier loriki to get there with the blood replenishment stock might actually die in the time that they wait for replenishment stock. The principle of distributive justice speaks to the fair, equitable, and appropriate distribution of healthcare resources. It also speaks to the allocation of scarce resources and the care of uninsured patients. And I love giving the talk to the public sector doctors in my country because, guys, you work your fingers to the bone to make sure that public sector patients get the absolute best possible care. I love numbers. This is something that I used to hate, and then when I did the postgraduate diploma on transfusion, Vernon was actually one of the people who taught me to love numbers. And the reason why I love numbers is they always tell you a story with just one picture. This is a very nice publication that was done between our current medical director, Karen, and Larice from Sasima down in Stellenbosch. And we looked at the red cell usage in patients over a 4-year period. And on the left-hand side, you will see the public sector. On the right-hand side, you will see the private sector. The right-hand side of each graph is females. Now you have to look at the public sector female population, the dark blue. And you look at this picture, the profile, and it looks like a pregnant lady. And that is really where the blood is going to in South Africa. It goes to the females, the red cells, let me be specific, the red cells of childbearing age in the public sector. So does all females have the same exposure? And you move to the private sector graph on the right-hand side, and you notice that it's a straight line. And immediately you start asking yourself, why are the females of childbearing age in South Africa predisposed to red cell transfusions? Is it because they can't access care fast enough and they kind of bled out by the time they reach a doctor? Is it because our antenatal care is in some way lacking, so that anemia throughout pregnancy, which is easily manageable, is not treated? I'm not going to mention the hospital name, but way back in 2017, I had a tertiary hospital in a more rural province, not Gauteng. And we noticed that this particular tertiary hospitals, the Ops and Gynae department, their red cell usage tripled. And I went to this hospital and I said, guys, what's going on here? Turns out the district level and the primary healthcare level in that particular province did not have access to ferrous sulfate for their antenatal clinics for a period of 11 months. So if I see this, my first thing is, where's the antenatal clinics? Is there iron in the primary healthcare sector? This is from the same publication. Now, if you look at the two columns right on the far right, it's the per capita use in the private sector, and left to it is the per capita use in the public sector. On the one hand, we're looking at 11s with 1 year where it was at 12, and on the other hand, we're looking at 34 up to 38 per capita in the private sector. So the question is, Are the private doctors wasting blood? Because that is something that a lot of people love to say. Yeah, those people in the private sector waste blood. I don't think they're wasting blood. So if you look at the average HB, average transfusion trigger for the private sector in 8 provinces of South Africa, and keep in mind that only 5 private hospitals in the 8 provinces that we cover have a blood bank on site. The rest of them have got off-site blood banks, because that changes your reasoning as a clinician completely when your patient starts bleeding. So are they wasting? I'm telling you now, they're not wasting. The average HB trigger is 8.3. How can you make a blanket statement and say that per capita use in the private sector is high because they're wasting? I'm coming back to my question about the public sector. What is missing? So a patient must reach a hospital. Can they even get to the hospital in time? There must be a doctor in that hospital to see them and to prescribe blood. What is the doctor to patient ratio in the public sector? If I think about things like orthopedic procedures, if I don't have prosthesis available for my public sector patients, I'm never going to end up doing the knee replacement or the hip replacement, so therefore I will never end up needing blood. So when I look at these numbers, I'm very concerned about the access to care and the level of care that our patients in the public sector have in South Africa. Now let's talk about the law. And although this little diaper-wearing devil seems to be very friendly and joking around, I promise you that is a very sharp pitchfork that he's holding. Chapter 2 of the National Health Act speaks about informed consent, not just for transfusion, informed consent in general. And it's very specific. The user, who's the patient, must have full knowledge, and the healthcare provider, which is us, must provide full information to the patient. You obviously then need the consent of the patient after you've given an adequate information. And the patient must have opportunity to participate in the decision-making process. There's a couple of instances where you can intervene without consent. We'll get there just now. And then here is where South Africa tends to fall flat on their faces, is our obligation to keep good clinical records. And the reason why I'm making that bold statement is because I see those hated little forms for 8 provinces of South Africa. That is the blood request form for SANBIS. And when I look at that blood request form info, because all the Meditech data pulls through to our business warehouse, and I've got a nice little BI report where I can spy on 8 provinces. Now, if you tell me that 80% of the request forms we receive for South Africa either don't have a diagnosis or have a diagnosis of anemia or anemia unspecified, I am telling you now, if that is the reason we put on paper why we expose patients to blood, then we are not keeping proper records in South Africa. What does Chapter 2 say about informed consent? It must be done by the treating doctor for a specified service in a language that the patient understands, and we often use interpreters, which comes with a whole different set of problems that we must be cognizant of, at a level of understanding. Again, you must make it possible for the patient to comprehend what you're telling them. So we can't say the patient don't understand or the patient don't comprehend while I'm using a lot of technical terms. You must communicate at a level that the patient can understand. It must obviously be written, documented, and there must be a witness to consent. Now, the witness to consent doesn't have the legal obligation to witness the content. The content of the consent discussion is the legal obligation and responsibility of the doctor. The witness only is responsible to say the process happened and there was no coercion. And then obviously if there's refusal of treatment, all the boxes must tell your patient, what are you going to do? Doctor did not keep up to date with your knowledge on the true risks of transfusion. You won't be able to tell your patients the true risks. If you as a doctor did not keep up to date with the hemovigilance data of your country to know how often HIV is transmitted, how often hepatitis B is transmitted, how will you put the risks into perspective for your patient? You also have to tell your patient about the available alternatives. Again, if Springbok doesn't have a cell saver, you can't be expected to offer the alternative to your patient. You have to have a discussion on the likelihood of success and the number of interventions planned. If you think of a long-term patient, ICU type patient, that's going to give more than one transfusion. The recuperation time and the cost. So in the private sector, cost is a very important discussion because medical aids are really pushing back on paying the bill and the patient ends up with 100,000 Rand bill. But in the public sector, we must still stop and think about the cost to our healthcare budget. Okay, let's move on. So when can you administer treatment to a patient without consent? First of all, I think somebody's not muted or I'm getting an echo of some sorts.
Yeah, it's
So first of all,
Ketiwe is not muted. Just ask
thanks.
Sahana if you can mute. Yeah.
Thanks, Graham. So first of all, if I as a patient mandate somebody on my behalf to consent, if the patient cannot consent, and there's not a mandated person, you can go to the spouse, the partner, the parent, the grandparent, the adult child, the brother, and the sister. The law as it stands still have an order. Now, think about, I'm from a very, and Vernon will tell you, Bloemfontein in the Free State is a very culturally strict, very conservative, very patriarchal society when we were young. So imagine I'm from a Free State farming family, and I've decided, you know what, marriage is not for me, but I do have a partner. And I've been living with my partner for many years, and my parents are not really happy about it, but you know, they just leave it now. And now I'm in an accident, and my partner knows that she won't want transfusion. She was against it. And my partner refuses on my behalf. And my parents goes like, you didn't even love our daughter enough to marry her. Now you want to make a decision that can kill her. So these are very sensitive discussions, and they turn ugly very easily. And then SANBS is phoned, and for some reason people think that SANBS can speak to the family on this, and we're actually not allowed to intervene. I can only emotionally support the poor doctor. You must approach these discussions very discreetly, very sensitively, because there are cultural hierarchies in our society. We've got a very diverse community in South Africa. Just be in mind that you don't contravene the law in the process. Treatment obviously can be authorized by a court order. I think you all know that. And when failure to treat poses a serious risk to public health, you are well within your rights as a healthcare professional to intervene without consent. When delay in treatment might result in death or irreversible damage, you may intervene, but the user must not have previously expressed or implied by conduct that they don't want the service. So think of your Jehovah's Witness patients, a lot of other cultural groups who don't believe in blood transfusion. If you've got any indication that that is the case, you cannot override the wishes of a previously competent adult. So Chapter 8 in Regulation 179 speaks specifically to transfusion. And Chapter 8, Section 59 used to say, only a registered medical practitioner or dentist, and the dentist always worries me, luckily they changed that, or a person acting under the supervision or instruction may administer blood. Let's stop there for the first bit. So we do not have the luxury of a doctor standing around in the ward supervising the sister while the blood runs in. So supervision not going to happen in our setting. So your second option is instruction, and that's very easy. Your instruction is prescribing the blood. If you give a written instruction on how you want the transfusion to be done, the nursing council agrees with the blood services that it's well within the scope of practice for the nurse to perform, to administer the blood. But it used to also say prescribe blood or blood products. And then clearly things happened that shouldn't have happened. And in 2012, Regulation 179 was published in the Government Gazette that was very specific that no blood or blood product may be ordered unless it's prescribed by a medical practitioner in writing on a form created by the blood service. So those of you who might perhaps also be working in a net care facility, they're already fully digital in their ordering process. We were very much part and parcel of developing the care on ordering form. So it's still a form created by the blood services. But Regulation 179 also spoke about hemovigilance and the participation in hemovigilance, and the fact that it's a legal requirement for anybody who plays a role in any part of the chain. And under hemovigilance, you've got all adverse events and you've got the look-back cases. So you can't decide, and we had an interesting discussion on Tuesday at a provincial meeting where two of the hospitals says, yeah, but if it's just an allergic reaction, we're not reporting it to SANBS. We don't have the time to fill the form. They actually don't have a choice. It's a legal requirement for them to report properly all adverse events that happen related to transfusion. So this is the hated form. And I know the Western Cape form looks slightly different, but it still has the same information. And there's a reason why we have this cumbersome form. Doctors hate this form. They say we ask too much, it takes them forever to complete it. First of all blood products by law must be traceable cradle to grave. In other words, every blood product that I get from a donor, at the end of the day, I must be able as a blood service to show it either went to a patient, it went to Petro, or it went to Vernon, or it went to whoever, or nobody received it, it expired, and I must produce a certificate of destruction of that unit. But there's a second reason why this block is very important, and we had a case like that on Sunday. I finished my call week on Monday morning, 8 o'clock, so I had to have at least one misdirected transfusion in my call week. It's tradition. And it happened on Sunday, where a patient received blood on Friday. Nothing weird, a straight A-positive blood group. We found compatible blood, units were issued. On Sunday, a new request form came in with a new sample. And our blood tech on the bench ran the test, and oh my goodness, the patient came up as a O positive. Turns out that they switched the samples. Now, had the patient's name been entered incorrectly on Friday or incorrectly on Sunday on the form, we would not have picked up that this is actually the same patient. And we would not have been able to pick up that there was somewhere a sample switch and that the patient actually received incompatible blood on Friday. I would not have been able to phone this fairly junior doctor in a fairly rural setting and talk him through to what he must watch out for, how he can go about in the treatment of the patient because the patient received incompatible blood. So making sure that your patient detail is correct every single time adds an additional layer of safety for your patient. Then the products that you choose. Do you know who must get irradiated blood? And I say must, not should, must. Who must get leukodepleted blood? So you need to understand the clinical condition of your patient, and you need to indicate the appropriate blood product. If I don't have an apheresis platelet available, and we're currently working with a patient like that, and we actually got a platelet from Western Cape Province flown to Joburg yesterday for the patient, because that's where we could find a match. But in the meantime, to pull the patient through, the doctor didn't have an option. They had to go for a pooled platelet. So the most appropriate, if we don't have it, we'll phone you and say, I don't have that. Can we discuss what is the second best thing we can do? Then that is the thing, the little block that I've indicated just now. It's a very big concern to me, especially in the private sector. That is where you as the doctor say, please do a standard cross-match, do an emergency cross-match, or don't do any cross-match at all. Now, the doctor should understand the different risk levels related to his choice. If I do a standard cross-match, it's a full cross-match. That unit is compatible or incompatible. We are fine. We are safe. If I do an emergency cross-match, I'm only doing the 20 degrees tests. I am not incubating the sample and I'm not running the sample at 37 degrees. So my warm reacting antibodies might very likely not show up. And your patient is kind of like 37 degrees. So you are putting your patient at an additional risk. I'm not even talking about uncross-matched blood. That's just like really, it must be life and death. Now, what happens in the private sector is the poor sister in the ward gets shouted at if she phones the courier unless it's an emergency after hours. So what does the poor sister in the ward do on behalf of the unsuspecting doctor? She wants the patient to get the blood. She goes and she ticks emergency cross-match on behalf of the doctor. The doctor is completely unaware of the fact that somebody has actually committed him or her to exposing his patient to a completely different risk level. So please be aware to fill your own forms. And if somebody else is doing it, please, I don't condone it. It's extremely dangerous. But best you find out as soon as possible what they're ticking on the form on your behalf. Moving on to diagnosis. And I've already told you, in SANBIS, the no diagnosis and the anemia or the anemia unspecified is 80% of the diagnosis that I received on request forms from the 8 provinces that I cover. Now, if the hospital file gets lost, and we all know that happens very easily, the hospital file gets lost, this legal document of SANBIS don't get lost. We were able to trace a form 23 years backwards. That's the longest case I'm aware of. So we don't get rid of these forms. We're going to trace the form. Now you end up in a court case. God forbid, but it happens. And they claim that you shouldn't have done this transfusion. And you're hoping for the clinical notes because you know you're a careful doctor and you would have written in the notes, but the actual hard copy file is missing. And the only legal document that is presented for the court case is this little form from SANBIS. And the diagnosis on the form says anemia, one word. There is no way you can defend yourself. So please, for you as the doctor, it's extremely important. For me as the blood banker and for your patient, it's important for a different reason. So I get phoned 4:30 Saturday morning, and my blood bank tech in Boksburg Blood Bank says, "No, Dr. P, yes, this is a funny one. It doesn't make sense. This and this and this and this is coming up." And I ask, what's the diagnosis? And the doctor has beautifully written me such a nice diagnosis that I can say, you know what, Rian, give me the doctor's number. And I phone the doctor and I say, we have seen that this and this and this, what you have told us your patient has, interferes with our tests. So the fact that I have got a proper diagnosis means that I can actually support you as the treating doctor so much better if we get irregular results in the labs. So this is where you sign, and we ask for a name and a signature and a contact number. And then you give me a short dialing code for whatever telephone somewhere in Barra Hospital. And that phone rings and rings and rings. And I can't get hold of the requesting doctor to tell him there's a problem with this cross-match. I'm seeing irregular antibodies. I cannot send you blood. Now the patient in the meantime dies. And the doctor shouts at the blood bank, who's responsible for the blood bank not being able to contact the doctor and discuss the patient? Is it the blood service, or is it the doctor who didn't give a contact number when it's clearly indicated in the form that we need a contact number? And you sign right below this little red block that says warning. And I prefer to do this talk in person because I ask the doctors, who of you ordered blood in the past month? And several hands usually go up in the room. And I say, who of you has read this warning in the past 2 years? And there will be a couple of hands remaining. So this is a legal document. And this is what you sign your name to on a legal document. You say that you as the treating doctor who makes the decision to expose the patient to the risk of a transfusion, you know that blood may transmit disease. You say that you know how the blood services collect blood. You also say that you know how the blood services test blood and what we test for. But you also say that in a country with a high prevalence of certain diseases, you understand that although the unit tests negative, there's still a risk of window period donations, and that you have taken this into consideration and you have discussed this with your patient. And then you went and you obtained informed consent. You also say that this transfusion is medically justifiable and that you did consider alternatives. And that is the form a doctor signs every time they order blood. And I can tell you now, doctors does not understand the gravity of signing a request form from a legal point of view. This is even worse. This is our form that goes with a unit of blood to an emergency fridge. So this is uncross-matched blood. It's being placed in that tiny little emergency fridge in the far-off hospitals who don't have blood banks. And we also don't know who's going to end up getting this unit. So it's a blank form. So first of all, life-threatening emergencies only. It's uncross-matched blood. Second of all, you as the doctor who makes a decision that you're going to expose your patient to uncross-matched blood, you don't have a blood bank on site. Have you ever stopped to think, how does the blood get here? Who brings the blood? In what type of cooler box do they bring the blood? Is anybody even checking the temperature when the blood arrives here? You must make sure, if these things are documented on the form, you must make sure if your hospital's policy are indicating the process and if you are happy that it's a safe process. Then again, we at the blood service don't know who gets this blood. And blood must be traceable cradle to grave or vein to vein, whichever one of the two happens. So we need the patient information. The 8 provinces that we support average about 15% untraceability. 15% of uncross-matched units that we issue, hospitals just never sent us back any patient details. So hospitals are in effect breaching the law 15% of the time. That's what it means. Also, O negative is as scarce as, I don't know what's the scarcest thing in South Africa. 2 years back it was electricity, but yeah. If you are going to use O negative blood when the patient is RH positive, and there is an RH positive in the unit in the fridge, you are negligent. And I am happy to take on anybody who try to prove me wrong. Last year in South Africa, in the 8 provinces that we support, 134 women of childbearing age who we know was RH negative had to be exposed to an O positive unit from the emergency fridge in an emergency. Most of them were postpartum hemorrhages in rural areas. The doctors did not have a choice. I spoke to 5 of them. 5 of them were on my calls. Those doctors were almost in tears. And I had to tell the doctor, you know what, doctor, at this stage, that's what you have. You need to keep your patient alive. We'll talk about the consequences after we've pulled your patient through the crisis. But my question is, then I went on a crusade about this. Then I went to look at the emergency fridges that SANBA supplies. It's just over 540 in the 8 provinces. And there were still certain hospitals that were allowed to only carry O-negs because the staff did not want to do RH rapid tests. So we obviously stopped that with very drastic speed. So you have to make sure your patient is RH positive or RH negative before you take that RH negative from the fridge. Back to the diagnosis. This is uncross-matched blood. Are you sure that your diagnosis tell us it's a life-threatening situation? And then again you sign, obviously, and there's a warning. Now, what happens? It's a crazy night. There's an MVA. You're always short-staffed. It was just horrific. It was one of those calls. And the doctor who struggled through this night with quite often only being 1 or 2 doctors available for this whole chaotic scenario, didn't sign the form, and he went off duty. And you are now the casualty doctor the next morning. And you walk in and you start your shift, and the poor sister comes running and she says, "Doctor, it was crazy here last night. Dr. So-and-so left. He didn't sign the form. And if we don't sign the form, the blood bank is not going to give us a replenishment unit." And what do? And I call you marshmallows because I was one as well. What do? We sign the form because our thoughts are we need to get blood in the fridge for the next patient who comes through the door who might really be a stab chest or a gunshot or whatever the case may be. But the reality is if that file gets lost, we who signed this form, this is going to be the document that says we took the risk to expose the patient to uncross-matched blood. Just keep all these little problematic thingies in the back of your mind when you sign forms for somebody else. So litigation is a reality in South Africa. I went onto a website about 2 years back and I typed in Transfusion Litigation South Africa. Ooh, beautiful, helpful website popped up. And it told me that faulty blood transfusions are one of the things for which litigation can take place. It also tells the public out there that you have got the right to look at your own medical records, charged information. Your own. Doesn't mean your family can page through it. These records can help you build a solid case. It's important to determine what outcome you hope to get by pursuing a medical malpractice case. A very helpful website. It also tells patients and the public out there what constitute negligence or medical malpractice. And it says, the doctor failed to obtain the patient's consent. The doctor didn't adequately explain the risks involved, and if you don't know the risks, you're not going to be explaining them. No. There was an administrative error or improper testing. So that can be the sample switch that we had on Sunday. We had it on Friday, we picked it up on Sunday. It could also be a blood bank technician that wasn't paying attention and he issued the wrong unit of blood. A blood transfusion was given when it wasn't necessary. If you do an inappropriate transfusion, South African law now says it constitutes grounds for negligence or medical malpractice. A blood transfusion was administered improperly. That blood lying at the nurse's station, sitting on the bedside table, blood being popped in bed with the patient just to warm it up for who knows how long, and nobody watches the total time out of cold chain if infected blood was transfused due to improper screening. And then it says, very helpfully, who you can sue. You can sue the doctor who performed or ordered the transfusion, the hospital where the transfusion was administered, and the blood donation service that supplied the blood. It is a reality, whether we want to accept it or not. It is a reality, and as much as we protect our patients, we kind of also have to protect ourselves. Ne? So just do the basics right. So when is a delictual liability? When harm or damage was caused intentionally or negligently. So if a reasonable person would have foreseen harm and taken steps to avoid it, but I, as the treating doctor, failed to take these preventative steps, I will be deemed negligent. And my conduct will be measured against a group of my peers, expert professionals in the same field that I am in. So in South Africa, if we as the blood server adhere to SANAS accredited, we SANAS accredited at all times, we adhere to ISO standards, you as the hospital have got a guideline that's based in good clinical judgment, good clinical evidence, and you adhere to that guideline, I promise you it's going to be extremely difficult to prove delictual liability. Criminal liability, different story. There are 2 criminal charges that can be brought against you in my field of work, and that is assault and culpable homicide. So assault I think is fairly straightforward. You administered a blood transfusion without the necessary consent. Culpable homicide is where you wrongfully or negligently cause the death of another person. And it can either be the blood service or the practitioner who was negligent, the patient demises, and then obviously you could be charged with culpable homicide. And I think we must all be aware of our legal responsibilities. Now, just as some background, in South Africa, there were 2 cases where healthcare professionals were found guilty of culpable homicide. And the one was a medical practitioner where incompatible blood was transfused to a patient, and later it was decided that the transfusion wasn't even needed. And the other one was a blood transfusion technologist who had patient Mukwena on Friday, and she was an A positive, and Sunday patient Mukwena's request form comes in, and it was 3 o'clock in the morning, and he's tired, and he says, I know this patient, I'm not going to run the sample again, I'm just going to issue an A positive again. So that was pure negligence, and the patient actually went in acute renal failure and died. So what are your responsibilities? Whether you are the doctor who order or the healthcare professional that transfuses the blood. So you only transfuse when it's medically indicated. You have to warn your patients of the inherent risks and tell them about available alternatives, and you have to obtain and document consent. Now that is easy. As doctors, that is 100% within our control. We can do those things. The next group is a bit tricky because we're not in the ward when the transfusion happens. No. You have to make sure the blood product and the patient is correctly identified, as well as the number of units to be transfused. You must ensure that appropriate compatibility testing has been done. The blood has been handled correctly prior to and during the transfusion. The blood is not expired, and only responsible people administer blood. So you're not in the ward. How do you ensure all of those things? And the answer is easy. When you go to work tomorrow morning, go and find your hospital policy on transfusion. And you start reading that policy with the eyes of a lawyer of a patient who suffered, not the doctor who knows the hospital. And you make sure that it actually covers all those steps for you in a way that you feel comfortable that the nursing staff who follows this policy will be able to tick all those boxes. Next, you must make sure that blood is transfused at a proper rate. Easy as pie, you just prescribe it, give the red cells over so many hours, or give the platelets first, followed by the red cells over so many hours, whatever the case may be. Next group is the tricky group again. You have to observe and monitor the patient before, during, and after the transfusion, manage any reactions, retain the samples and the empty packs as the blood service requires, and report reactions of death. And it takes you back to your hospital policy that you must go and scrutinize and see whether it is adequately covered by your policy. And then we're on to the hemovigilance, the surveillance programs. You also have the legal responsibility to trace, counsel, and test recipients of transfusions that we identified by the Look Back program. If you can tick all those boxes, I promise you the best possible outcome for your patient. Because if you can tick all those boxes, you have automatically made sure that your patient did not receive a transfusion which they didn't need. So, in conclusion, please empower your patient with adequate knowledge, appropriate information, and allow time for them to discuss that with you. Always consider the 4 ethical principles and don't limit your patient's options because your knowledge got outdated over time. Know your legal obligations and your responsibilities. Always apply PBM measures in time. Don't wait until the obstetric patient is bleeding. Start applying it from the first time you see her in the antenatal clinic. And always screen for and treat anemia. I'm happy to take questions. Thank you very much.
Thanks so much, Petro-Lise. I think we're all a little bit quiet now, having listened to all of this. So it was a huge eye-opener when I've also realized for the first time what all the implications are of what we're doing when we're giving blood. Are there any questions or comments from anyone in the audience? And you're also welcome to put a question in the chat if you'd like to. While we wait, I just want to mention that for those of you who do not know much about patient blood management, we have a virtual conference this weekend, Saturday from 12 to 4:30. Petrolise will also be speaking there. Anybody want to recommend some colleagues to come? I'll be giving 2 talks as well, and we've got a speaker from the UK and also Professor Tsebetsa from Gauteng, cardiologist, giving a very, very important talk. And I think it will be very useful to get a primer on patient blood management, where it comes from, what it is, how it works. I really like to invite you all to come. I've just shared it on the GenMed group. You can just click on the link and register. I think 3 days ago or so, we had about 800 registrations.
Yep.
But there's definitely space for more. We know not everybody pitch up at the end of the day. Okay, so I don't see any questions right now. Petrolise, thank you very much. Maybe if I can ask you one question, one practical question. How much of this process can we outsource to the nurses?
That is a question that we at the Blood Service always battle with, because, and please, I am not giving permission to PP sign on behalf of anybody. I'm going to share with you the things that we are still grappling with. The law is written as I've quoted it there. That is how the words look like in the law. The thing is, we know that there's room for telephonic prescription, and there's rules for telephonic prescription, even well up to a certain schedule of drug. Now, if we want to extrapolate that to blood products, we need to be able to attach a scheduling status to a blood product, which we can't do, because until the time that we become supra-regulated in South Africa, we meaning the blood services, how do we say, okay, but this equates to a Schedule 7, so no telephonic, or this is a Schedule 5, we can still go for telephonic. And that's the problem we are grappling with in the blood service, because we get asked this question very often. And I do think that is a question that until we've got clarity from powers outside, because blood services can't govern ourselves and we can't rewrite the law or interpret the law as it stands word by word. I think until such time, it's best to take this question to every hospital's legal department and ask them, are you comfortable if we follow a telephonic prescription? I'm just making an example. If we're following a telephonic prescription protocol, are you okay if we do this in our hospital where a doctor can telephonically prescribe blood? So, Vernon, I know it doesn't answer your question, but I have been struggling since 2018 when I started in this portfolio to try and get a definite answer. And there is no national body in South Africa that's willing to give me a definite answer on this. So until such time, I think it's safer for every hospital to discuss this matter and decide what they feel comfortable with. But the law stands as it is written, that I've showed you the extraction of Regulation 179. But then also we know that there is room for telephonic prescription of other substances.
No, thank you very much for that. And I think the actual law on blood and blood products there's a great need for improvement in that document. We've made submissions in the past, but nothing has changed as yet. Professor Cherry has got her hand up.
Yeah, thank you so much. I don't want to belabor this meeting, except to say, Petrolise, every time, this is the second time I'm hearing this, and I find it sobering, and I still learn new things every time. And I think it's not so much about protecting ourselves, which it is, but also about ensuring improved outcomes for our patients and just basically doing the right thing. And so I just wanted to thank you for agreeing to do this talk. I will invite you again, maybe
Thank you,
face, because I think we cannot hear this enough. If we just start by doing the right thing, the other stuff will follow, and then the legality is also something that can be worked on. But my sense is that in the wards, we take this for granted. We probably don't supervise our interns sufficiently. We leave them to their own devices. The nursing staff is unsupervised, and yet we prescribe this fairly frequently without giving it the due diligence. So thank you indeed, and thank you for the patience with the technological issues at the beginning, and thank you so much, Vernon, for chairing. Much appreciated.
Mashiko, if you will allow me a comment on that, I think that's the beauty of patient blood management. If we think patient blood management every step of the way, we will automatically be ticking the ethics boxes and we will automatically be ticking the legal boxes. So all we have to do is think patient blood management and the other stuff will fall into place. Thank you so much for inviting me.
Thank you, Petrolise. I think there's some important comments in the chat. Professor Mark Blockman, happy to help with SAPRA and the Biologics Committee. Prof. Graham Manchis, need to get this message to junior doctors, absolutely. And Dr. Rob Gill, do you think it's feasible to enforce mandatory accreditation for healthcare professionals who are involved in transfusions at all levels, doctors, nurses, etc.? Might it reduce adverse reactions and wastage?
So I'll start from the top. Dr. Blockman, any help we can get from blood service in South Africa, we will really appreciate, because we do need some answers on certain things. So I'm going to take you up. I'm going to try and put you in contact with the person in SANBS that works with that, because please, any help, just thank you. And then the junior doctors, Graham, we were successful so far to get into 4 of the undergrad programs of universities in South Africa. And we hope to be into 7 formally. Some is informal, 2 are formal. We hope to be formally in 7 medical universities in South Africa within the next 5 years, where we are a formal inclusion into the undergrad program of the 5th year medical students. And the Free State, I think, is going for their 8th year now, that we are formally included in the 5th year program. And then, Rob, so it's feasible. I want to say yes, 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 yes. And I always say that I think back to when I was a younger doctor, and they started with the maternity safe, the breastfeeding hospitals, and everybody thought it was ridiculous. But here we are now, and hospitals are kind of required to be breastfeeding accredited, so to speak, within DOH themselves. So what prevents us to do the same for our patients when it comes to transfusion? What prevents us from, and I had a nice little plan written up for a private hospital group, and it never got off the ground, but what prevents us to have a checklist and an accreditation program for hospitals to say, okay, you don't have to do everything at once. Level 1, just start with a hospital policy and training of your healthcare workers. Level 2 is when all your healthcare workers are trained or retrained and you can add on the bells as you go, thinking about making sure that there's a committee that monitors the practices in the hospital. So I want to say it's very feasible. But we need a hospital to start doing this first and then write it up, that the rest of South Africa can see, listen, even with our resource constraints, it is doable. And then write up the benefits to the patients after you've been doing it for a while. And then we get buy-in from the bigger crowd. And hopefully then it will become mandatory after a few years. So I think we can do it. I really think, and should we? Of course, I think we should do it.
Wonderful. And as an easy low-hanging fruit, something we used to do in the Free State with our doctors, there's an online course, very short course, Blood Safe e-learning from Australia. It's wonderful. It's interactive. It covers all the very basics. They've got much more advanced courses as well. But this course is really, really useful. And it gives the doctor a certificate at the end of it. It takes only a few hours to complete. So really, really will give every young doctor confidence as well in how to administer blood, how many hours, which types of blood to use, when do you use irradiated, leukodepleted, and all the rest. It's time to say goodbye. So, Petrolise, thank you very much. Thank you so much again for your time. I hope you will come back, like Professor Chelly said, and come and do this again for us. And we really, really take note of what you've shared. And I think all of us are going to aim to do better. I want to check what happens at 12 o'clock midday in the clinic, when the end of the day is looming and blood is ordered, whether that emergency block is ticked or not. I want to go and check that tomorrow. A lovely day to you all further. And thank you everyone for participating in this meeting. Bye-bye.
Bye, everyone.